And I'm going to go ahead and introduce our next panel. First panelist is Rosalie Apicula. Rosalie is the Elizabeth Garrett Chair in Health Policy, Economics, and Law at University of Southern California. Her research focuses on illegal and imperfect markets, where she has applied much of this knowledge to study addiction and addiction policy and how the healthcare system delivers and finances treatment for addiction services. Brendan Saliner is the Bloomberg Associate Professor of Addiction and Overdose in the Department of Health Policy and Management at Johns Hopkins Bloomberg School of Public Health. One of his research focuses, among multiple, is on access and quality of care for people with mental health and substance use disorders, and he has prolifically investigated the impact of federal and state policies on access to care and outcomes related to treatment. Ben Linus is the Director of HIV Epidemiology and Outcomes Research in the Department of Medicine at Boston Medical Center and is a Professor of Medicine at BU. His research investigates the comparative and cost-effectiveness interventions to identify and treat medical complications of substance use disorders. Dr. Linus also directs the CHERISH Population and Data Modeling course, so he is a partner in all things CHERISH related, and he and his colleagues have developed a dynamic population model that simulates the trajectory of opioid use disorder and treatment effects on drug use and overdose in Massachusetts. Joining Ben is Mathieu Castri, who is a postdoc research fellow in Dr. Linus's lab. He has applied simulation modeling to estimate the effects of licensing regulations specifically on overdose outcomes. Today's panel will be moderated by Michael Botticelli, who needs no introduction, has really been more than 2 decades at the, has more than 2 decades of experience supporting Americans affected by substance use disorder. He is the former director of the National Drug Control Policy, drug czar for the Obama administration. He led all of the Obama administration's drug policy efforts based on a balanced public health and safety approach and coordinated actions across the federal government to reduce prescription drug abuse, heroin use, and overdose. Before that, he was the director of the Bureau of Substance Abuse Services in Massachusetts, where he successfully expanded innovative and nationally recognized prevention, intervention, treatments, and recovery services. So with that, I'm going to hand the mic over to Michael Botticelli to moderate today's research panel.
Great. Thanks, Zach. It's really a privilege to be here today, not only with colleagues on this panel who I've had the pleasure of working with and learning from for a very long time, but your other presenters as well. I want to thank the Arnold Foundation for funding this effort, which has been tremendously important to me for a long time, and also to CHERISH. I've had the privilege of being involved in CHERISH for the past few years now, and I think it's really important, quite honestly, to think about how we infuse a lot of our research efforts with the view of policymakers. I'll take the liberty of saying that I've probably been at this tip of the spear of criticism from the research community about how come you don't implement kind of all the things we know to be effective. And I think how we heard quite convincingly that it takes a wide variety of tools to actually move policy. This issue is really important to me. Back in 2008, 2009, as we had gone through healthcare reform in Massachusetts, we had a very large Medicaid benefit that included all 3 medications. We were doing a tremendous amount of expansion in the use of medications, largely through the great expertise of my colleagues at Boston Medical Center. But we continue to hear that access in our residential system for those who are on medication remained a problem. And while we had a number of early adopters, we weren't quite honestly successful in using other tools of persuasion and data to show our residential programs to do it. So we undertook a process to rewrite our regulations and infuse them with kind of quality measures, including a prohibition against discriminatory admission practices for people on medication. That was very contentious, both within the provider community and particularly within the legislator community. And I'm grateful that we are here today to have some data and some findings to help support policymakers in their effort to do that. So I'm really thrilled to be moderating this. Our first presenter is someone who I've had the pleasure of working with for a very long time in his role at Johns Hopkins, Brendan Saliner, who has been doing a tremendous amount of work interviewing state officials who have implemented similar licensing requirements, and I think will present some really interesting lessons learned from what they've experienced and how that can guide the rest of us in this work. So Brendan, I'll turn it over to you.
Thanks so much. And I'm going to try not to gush too much, but it's just such a pleasure and a thrill to be here with so many friends and mentors. And Michael, you're one of my personal heroes. I'm going to go ahead and try to share my slides. Let's see how this works. Hopefully folks can see this. All right. Well, I'm going to just start off with some acknowledgements. So this is part of a grant funded by Arnold Ventures, and I really want to thank Arnold for their support and actually for bringing this project to me. This was not an issue that I knew much about a couple years ago, and Arnold said, hey, would you like to look at this issue? And here we are now, and I've learned so much through this process. I also want to, of course, acknowledge my amazing team at Johns Hopkins. Aline Kennedy Hendricks in particular was just such a leader in doing some of these interviews with our state contacts, our state officials, treatment providers, and advocates. And our funder, of course, Arnold Ventures. And just to caveat that what we present here are certainly our own views and don't necessarily represent those of our funder. So this presentation is one piece of a larger project. Actually, if you were watching the earlier panel, Karen Stubbs did such an amazing job of sharing some work that we're working with her team in Louisiana on to look at their residential requirement. And we're also doing some national policy evaluation. But this piece of it is really more on the implementation of licensure policies in states. And today I'm going to just share with you some findings from 25 interviews that we did with state officials, with advocates and providers in 5 states, Louisiana, Missouri, New York, Massachusetts, and Maryland. These are 5 states that are ahead of the curve in terms of using licensure authority to promote access to MOUD. They don't all have exactly the same kind of policy, and actually one big task that we've been trying to dig into is just characterizing what the state policies look like, how they work in practice, and we may have a chance to talk further about that in the Q&A. So I'm going to present some quotes from these interviews. We've lightly edited them just to make them a little bit more readable here. And just to caveat that these are preliminary findings and we're doing a more full-scale content analysis. So please take these as preliminary. So the first major finding from our work, and I think this certainly was foreshadowed in the prior panel, is that licensure can be a very effective stick, but that there's a lot of carrots that also matter. So a lot of our interviewees believed that there was still an important role for persuasion, but some of them really did lean into this idea that mandates are sometimes necessary to get to a point of access in a more universal way. So for example, one treatment advocate said, I think the soft approach is nice, but the only real way to make change is when there's a consequence associated with it. Similarly, a treatment provider says that we have to help force that change. And the only way to help force that is to insist that they change. So all the education in the world doesn't always change minds. You need something else involved in that change. And that something else is some kind of requirement that the law change or that the policy be implemented. This policymaker noted that in some states, the Medicaid programs might not be that innovative, or there might not be other ways to push the bounds. So you kind of get left with blunt instruments. And this idea that licensure is a blunter instrument came up in some of our other interviews as well, that, it's one kind of tool in a possible suite of tools, and that maybe, it can be helpful for certain kinds of change, but certainly has to function within other policies and practices. Another big finding from our work is that there's a huge role to be played for not just having the rule or regulation on paper, but actually for having robust monitoring, enforcement, and technical assistance. So it's one thing to tell providers they have to provide access to medications, but the state has to be able to have some good auditing and oversight practices, and also to be able to do some outreach and education with providers to help them kind of understand how to be in compliance with the law. This policymaker talked about the front end and then the back end, and the front end was really about doing the policy and procedure review with the provider, but then on the back end, they process complaints from people who may feel that the provider is not meeting the requirements, and so they also have an avenue of redress. Another state policymaker told us, that in their state, they have a certification process that happens every 3 years. So they needed some other way to reach programs. So they ended up just calling up programs and saying, what can we do? What are your challenges? Do you need somebody to come and talk to your staff? And then another advocate kind of emphasized that in their state, putting the requirement in place was just the start of a process that also involved kind of letting the programs know that they were there to provide technical assistance and outreach. Third major point, and I think that this is a really important one for the moment that we're in, is that programs kind of came in a variety of different orientations, and that certainly there was some of that more traditional kind of stigma against medication, but there were also some more sort of nuanced issues that came up when dealing with providers that said that they either weren't able to or didn't want to implement an MOUD requirement. So for example, this policymaker talks about, there were people who said, how could you offer medication-assisted treatment to people who are unable or unwilling to participate in psychosocial treatment at the same time, and it was seen as devaluing psychosocial treatment or not holding people accountable. So this kind of gets into a bigger discussion that's being had in the field about kind of a medication-first approach or a low threshold approach. And in a very similar way, this policymaker talked about some programs, feeling like medication first, which was the state's stated orientation, was medication only. And then this person says, well, there's a lot of getting providers to think about treatment differently. Yeah, get that person the medication they need because it's life or death. But if the person doesn't want something right away, that doesn't mean you don't continue to work with them to get them to a point where they'll engage in counseling. But, and I think, I don't want to sweep under the rug the fact that some providers we talk to really don't, because they don't believe that medication is treatment, want to offer it. So this person told us if someone's prone to addiction, replacing one opioid with another mood-altering substance is not to their benefit. So I'm really not a fan of anything narcotic to wean someone off a narcotic and put them on another narcotic. This also gets to a point that came up in the last session about the idea that licensure laws are strong when they work with other kinds of funding vehicles. So in particular, states have the opportunity to integrate this with their Medicaid programs, and also that their Medicaid programs sometimes provide them with a hook to really change services for providers that participate in Medicaid. So in this example, the county in this state must ensure that those that they contract with for Medicaid are meeting terms and conditions. So they just write it into the contract for payment. So this is actually not licensure, it's contracting, but it gets at the same kind of goal. This other provider actually talks about some of the unintended consequences of how reimbursement was set out. So the funding model was really upside down. We were running off a system designed for acute care and didn't take into account the cost associated with physicians, nurses, et cetera. And so you're almost disincentivizing your best practices. So part of their way of getting to more medication access was to try to change the structure of how they reimbursed for different kinds of services. The idea of an 1115 Medicaid waiver, which allows states to deviate from the normal statutory requirements of Medicaid, came up in some of our interviews. And so in this case, as stakeholders to the state, we're at the table and pushed a lot of what exists today through the stakeholder process with the Department of Healthcare Services. So these 1115 waivers, and in particular, the SUD IMD waivers have given states a little bit more leverage to kind of build out a continuum of care that is inclusive of medication. We know that one state now has gone farther than any state, that's California, and how they've included mandates for medication through their 1115 waiver. Overall, I would say mixed views on how much licensure laws actually change MOUD access for actual patients. Some felt that they accomplished major changes. Others felt that the laws didn't do much to change the underlying reality. So this person said, any provider interested in quality and outcomes is going to see that medication is helping. They're going to see these results and naturally get on board. My gut is that legislation doesn't have much to do with it. This treatment provider said there's still those folks that are holdouts, that you really need those sorts of regulations to keep pushing them to get them on board. And they're likely going to get on board, and some of them will do a bare minimum to demonstrate their compliance. So kind of getting to providers to a point where they're formally in compliance may not totally shift the reality of what kinds of services they provide to patients and how they counsel patients and sort of the subtle and not so subtle things that they say to patients. And then this person said regulation was important early on, but frankly, I feel like it sort of faded into the backdrop because it's not really needed anymore. We would look at you like you had two heads if you were telling me you didn't do medication at this point. So kind of really important in creating kind of a new mentality in this state early on, but then kind of other things take hold and it becomes more organic to just provide medication without coercive kind of requirements. So when I wrote these slides, I thought of it as the last mile in medication access. From thinking about the last panel, maybe I think of it as the red zone problem or the goal line problem, that this is really about kind of pushing the ball over the goal line. So it does seem to be important in getting to some of these final programs and getting toward more universal access. But it depends on a larger infrastructure. You know, it's predicated on an idea that there's financing, auditing, and provider outreach. So again, thanks for your time and attention. I look forward to the discussion.
Great. Thank you, Brandon. That was, I think, really helpful in one, just kind of illustrating the broad spectrum of attitudes of even states who've implemented these policies, and still how far we have to go to kind of move people kind of along in the process. You know, as we heard from just about every panelist, you know, kind of state licensure requirements is one tool in a much larger policy arsenal that we have here. And I think we've seen that. So we're really fortunate to have Rosalie with us today to really take a step back and look at the kind of broader policy influences and policy levers that states are implementing in their response to issues of addiction and the opioid crisis, and to look at kind of what they're considering around evidence-based treatment. So with that, I'll turn it over to Rosalie.
Thank you so much, Michael. And it really is an honor and a pleasure to be here today with all of you and seeing so many familiar faces. Like Brendan, I want to acknowledge some contributions made by my fellow collaborators, both at USC, Seema Pesser and UMNG, as well as colleagues at the University of Arizona, Annie Bousted, a lawyer, as well as a policy analyst, and Rosanna Smart at the RAND Corporation. Some of the results I'm going to be presenting to you today about that kind of provides the layout of the network of policies, both federal and state, that matter for influencing access to medication for opioid use disorder, was funded by the NIDA P50 Optics Center, Opioid Policy Tools and Information Center, with my colleagues at RAND. And so I want to acknowledge their support, but I'll also be presenting to you today some really valuable legal policy data that's being done by a different NIDA-supported project at Temple University, the Prescription Drug Abuse Policy Surveillance Group. For any of you that are very interested in understanding what is happening across the states in licensing and how your state might compare to others, I highly recommend you look at their webpage. So, as Michael already said, there is this myriad of both state and federal policy laws that influence medication for opioid use delivery. And the treatment setting influences which laws apply, but the laws are diverse and complicated regardless of the setting. As has been already said by Dr. Olson in the previous panel, prior to the epidemic, prior to the current pandemic, there was much more rigid laws and policy in place. And one of the blessings of COVID, and if we can say that there have been any blessings from COVID, has really been this opportunity to try to break down some of the regulations and barriers that were just so common in this area and taken as a given. Prior to the pandemic, access to providers was very, very limited. There were 40% of US counties that lacked a physician authorized to prescribe buprenorphine. In addition, access to facilities was a major problem, with 18% of patients receiving care in OTP facilities saying that they had to drive at least 30 minutes or more to get there. Telehealth delivery, while technically allowed prior to the pandemic, was highly underutilized because of stringent requirements both at the federal and the state level with respect to how that telehealth visit could be delivered. It had to be done in certain ways, which limited the ability to meet HIPAA requirements that required certain types of protections on those sort of communications, as well as the need to have direct written consent because of privacy laws. There were all sorts of requirements related to having a pre-existing relationship with the clinician prior to initiating any sort of telehealth visit, or that you have an in-person consultation prior to. And then of course, there's the payment issue that has already been brought up in multiple panels. Let me kind of walk you gently through kind of what the world was like prior to COVID as well. This is data from the Prescription Drug Abuse Policy System that is providing information as of August 2020. And what it's showing in this example is that, look, state licensing restrictions for specialty facilities are really quite common, and they cover a variety of areas and topics. This one's showing that mandatory drug screens are required for any OTP in 40 different states prior. And well, this is actually after COVID got started. If you're requiring a mandatory drug screen when you're having difficulty getting patients to come in, that's going to be a major barrier, even if you are providing effective treatment. And while some of these regulations are highly restrictive and fairly common, the regulations that provide access to best practices, such as facilitating access to medication for opioid use disorder programs, are far less common in state laws. Only 8 states as of August 2020 actually had a requirement to facilitate this, Louisiana being one of them, which we've heard a lot about today. Some of these state regulations really can hinder access to the facilities themselves, not just the medication. For example, in 8 states, there were restrictions on where OTPs can locate, including in close proximity to another OTP, which is a concern because in cities where there's a high dense population, having these sort of proximity restrictions can be a major concern in terms of actually providing access to the patients who live in those areas. Also, if facilities are going to require mandatory counseling in order to receive MOUD, which 6 of these 8 states do, having childcare facilities not in close proximity, again, creates an additional barrier. What do you do with your kids? If you have kids, how do you take care of them while trying to do this mandatory counseling in order to receive your medication? The regulations are not just specific to treatment facilities. There's also many state regulations that are specific to office-based opioid treatment. 11 states specifically impose particular regulations. I'm not saying they're general regulations, but 6 of these also require the counseling in order to receive medication for opioid use disorder in an outpatient setting. These, again, these are laws in effect as of August 2020. They might have changed since then. So COVID really came along and opened doors that were not previously available to patients because of basically changes that had to take place in order to facilitate patients receiving care not in person because of the pandemic. As everyone in this audience probably knows, prior to COVID, the federal law mandated that methadone could only be prescribed in an OTP which were regulated by SAMHSA, as already mentioned by Dr. Olson. Doses had to be generally delivered on site daily to the majority of patients. At home delivery could only be done under certain circumstances, very limited circumstances, and only if the states also allowed it. This was a federal law, but the states also had to enable their changes in this. The Ryan-Haidt Act, because DEA also has authority to regulate methadone as well as buprenorphine, the Ryan-Haidt Act allowed, or DEA required that anyone receiving this medication had to have an in-person medical evaluation. So it wasn't just a requirement of SAMHSA, but it was also additional requirement of the DEA. With COVID, SAMHSA issued a number of exemptions enabling clinicians practicing in OTPs to initiate both buprenorphine as well as methadone to new patients without an in-person evaluation. The waivers also granted waivers for on-site daily dosing, allowing some of these doses to be delivered through home delivery with authorized personnel and law enforcement, or for stable or unstable patients, depending on the decision of the doctor, to receive up to 28-day or 14-day, respectively, dosages. But in order for OTPs to actually get these privileges, they actually had to seek their own waivers. So states actually had to go get this blanket waiver. And as this map shows you, both the blue indication as well as the orange, there were actually 42 states that actually sought these SAMHSA OTP blanket waivers. 4 of these states, however, did not also apply for the DEA buprenorphine waiver for that allowed people to provide buprenorphine without an inpatient visit. So there were actually, showing you here, 7 states that didn't implement either of these policies. So even though the federal government was expanding access through these waivers, 7 states did not seek these exemptions to enable their OTPs to actually do them. Telehealth policy has been instrumental in expanding access to providers, but as I mentioned before, states also had their own restrictions, so it's not just a function of what the feds were doing. 41 states during COVID actually waived the requirements of prior in-person evaluation in order to initiate medications for OUD, and 22 states actually waived the requirements of clinician-patient relationships. The fact that these were actual requirements in the laws demonstrate the type of barriers that exist in delivery of this type of treatment, unlike other areas of treatment, and are important to keep in mind. As we've spoken about already, payment reform was a critical part of this. For general healthcare services, payment parity, payment parity was in Medicaid adopted in most states with part of COVID, with 42 states plus DC passing some sort of payment parity as part of COVID. But private insurance were a little bit less common to require this parity and mandate it for private insurance. In the case of mental health services, though, states were not as common to implement these parity payment models. And so payment for these telehealth services is critical to make sure that patients actually have access to them. Telehealth also has to comply with both federal and state privacy laws. Most of you know about the HIPAA requirements for general health care, and in the case of substance use treatment as well, there's the additional privacy protections granted by 42 CFR Part 2. Some of these were waived during COVID as a way to increase access to patients, particularly the need to get written consent from the patient, where you actually have to see the patient and prove it's the patient in order for them to have this waiver exist. So with COVID, these waivers were granted in many, for the federal government, it was CMS waivered it within Medicaid specifically, but additional state privacy laws also have these rules, and only 9 states relaxed their policy laws that facilitate this sort of telehealth delivery by foregoing the waiver, the written waiver. So what I'm trying to highlight is that while states were very aggressive at tackling barriers for general healthcare services, in this case that I'm showing you in this graph in the blue bars, almost all states waived or loosened restrictions for out-of-state physicians to practice telehealth for general healthcare service. And many states in the gray bars expedited licensure for retired or inactive clinicians to provide general health care. For providers that are more often engaged in prescribing buprenorphine, specifically nurse practitioners and physician assistants, the states were not as aggressive in expanding privileges for these types of physician extenders who were very critical in providing treatment. For those states that did expand, because by mid 2020, most states expanded privileges for physician assistants in particular, they didn't always allow for the rights to prescribe both buprenorphine and methadone. Only 40 states by August of 2020 allowed physician assistants specifically to prescribe both forms of medication, because some patients are not as responsive to every type of medication. So in pulling all of this together, it creates a very complex regulatory environment in which doctors and facilities are trying to operate and provide evidence-based practices. What I'm trying to show you here is pulling together certain elements of all these different policy domains I just discovered by state. Each little item along this policy wheel represents a particular state organized by geographic area. The blue squares are identifying those states that I mentioned previously that did implement both the DEA and SAMHSA waiver for expanding medication access. The gold ring shows states that expanded broader scope of practice laws for both nurse practitioners and physician assistants for prescribing medications for opioid use disorders. But the gray blocks here represent the relatively few states that explicitly address their privacy laws restrictions to facilitate telehealth delivery of treatment for opioid use addictions. And then the purple show how the states that expanded telehealth coverage across all dimensions that would enable a true telehealth visit for patients seeking OUD treatment who might also want to use a medication for opioid use therapies. And what you can see is that relatively few states adopted more than 2 of these policies during COVID to enable access to telehealth and medication-assisted therapies. Most states used 1 or 2 approaches. Very few, there's none that adopted all 4 and made sure all boxes were checked to enable treatment for patients. And so when we think about barriers within a particular setting, we need to think beyond just the availability of medication-assisted therapy, but also in how it's being delivered. The telehealth through COVID was a major mechanism. Most states use a variety of different strategies for delivering healthcare, and some of these are more restrictive for addiction therapy than for general therapy. And so it's really important to consider this whole broad environment when evaluating the effect of any particular strategy or approach. Most researchers tend to get excited about one particular policy that gets adopted, and they're really enthusiastic about that, forgetting the overall environment in which that policy is being implemented that might facilitate or reduce its effectiveness. And so in thinking about this as a policymaker, as well as a researcher, our work is just trying to expand how people think about the entire environment for improving access to evidence-based therapies.
Great. Thanks, Rosalie. I want to take the opportunity to ask a couple follow-up questions to your work. I think most people would agree that these changes were long overdue and should be institutionalized, and it was great to hear Dr. Olson talk about SAMHSA looking at that. Are we seeing any data or evidence to support that all of these changes did in fact increase access to care? And I know it's very hard because we don't have baseline data is really hard during the pandemic, but what evidence do we have that can help support our case here that these were really important regulatory changes that ultimately did expand access?
So there's I'd say a moderate amount of evidence that suggests that the broadening of the scope of practice laws have been very effective at expanding access to healthcare, particularly for patients suffering from OUD. In terms of the telehealth visits, I know that there's work going on right now. I think this is one where we have to be particularly careful of the broader environment, to the extent to which payment reform was also included in the adoption of the telehealth specifically for OUD, as well as the privacy law. And most of the evaluations I've seen thus far are not, considering the overall environment. And so while we are seeing evidence that is definitely including expanding access, we don't know to what extent this is truly influencing uptake and utilization, because we don't know how well all these barriers are being reduced. We need more work, unfortunately.
Great. I want to channel my friend, Dr. Ben Linus, in this question, who noted that while many states adopted practices, that there were a considerable number of states that didn't do anything. And I wonder if you have any reflection or thoughts on kind of anything thematic in those 7 states that we should be paying attention to, and what might be possible solutions to move them along.
It's a great question, very good question for somebody like Brendan, who's better at doing some of the qualitative research and not just the hands-off 50,000 view. I can't say that I have looked closely at it, but I think it's a very natural question that comes from the work that we've done so far.
Good. Brendan, do you want to, any thoughts you have on that?
We don't have any data really to speak to that question, so I think it's worthwhile to dig more into it. Thanks.
I couldn't get a personal opinion out of you.
I think better to leave my speculations for another day.
Great, thank you. So now I'd like to turn it over to 2 colleagues who I have long turned to for a very long time in terms of helping guide our approaches both in Massachusetts and nationally. Ben and Matthew have done a tremendous amount of work in a wide variety of areas, but I think germane to this conversation, doing some modeling on kind of the impact of implementing these sorts of regulatory changes, and what the impact, the potential impact could be in a Massachusetts model. So I'll turn it over to them for their presentation.
Fantastic. Thanks, Michael. I'll open up and I'm going to turn it over to Mattia. Thanks for having me today. It's really an honor to be here. My name is Ben Linus. I'm a professor of medicine at BU, and I lead this endemics lab at Boston Medical Center, and we work on a variety of projects focused on the medical consequences of substance use disorders. So next slide. Thanks. With this, just briefly on background, we've all been here for a couple of hours talking about these issues, but to provide a little bit of perspective, we know that medications for opioid use disorder have been proven effective in treating OUD and improving almost all substance use outcomes. Residential treatment is one form of treatment for OUD that's commonly used in the United States, but at this point, despite a lot of the policy changes that we've been discussing for the last hour or so, we still see insufficient MOUD use in residential facilities. So a couple of data points, and this is from data from 2017, so getting a little bit old, but recent surveys showing that only 40% of residential treatment centers in the US make any offer of an MOUD to patients coming into the residential treatment, and that at the end of the day, only 15% of admissions include MOUD treatment. And so we've been looking for ways to improve upon that, and working in collaboration with Zach and others and this Arnold Foundation project, trying to think about could we develop state licensing standards that help to address the MOUD gap in residential use. Next slide. And our approach to doing this is to use a simulation model. And briefly, I'll say simulation models simulate a hypothetical population of people, in this case with opioid use disorder, to experiment with policy or regulatory or guidance changes to understand what those changes, what impact they might have. And an interesting thing about models is that they allow us to take short-term outcomes from things like clinical trials or observational studies and to extend them to longer-term horizons. They also allow us to take data that was observed in a cohort and to ask the hypothetical what might happen if we were to intervene in some way, and then look at outcomes that potentially weren't necessarily empirically measured in the initial study. So it allows us to integrate all different types of data and then to experiment in almost a virtual policy lab to see what one might expect in the real world were we to implement those policies. So we're today going to be talking about our work using what we call the Wristband model. Wristband is researching effective strategies to prevent opioid death. This is a R01 sponsored by NIDA, and we've been doing a lot of projects with this model over the past couple years. And in this case, what we did is we used our model to simulate the efficacy of offering MOUD to patients who are entering residential treatment and then linking patients to outpatient MOUD care upon discharge. And our question is, what might that look like, both for the patients in a residential treatment center and also for the population in a state, the general population with opioid use disorder, if those policies were put into place. And one thing I'll mention now before Mathieu gets started looking at the data is that we did not in these simulations ask the question, what would a change in policy do to the actual real world offer rate of MOUDs in residential treatment? I think that's an important question, and we can talk more about that. But today what we're doing is saying, supposing treatment centers actually did begin to do this and offer MOUDs, what might the world look like, such that we have some sense of what are the outcomes to which we're striving and what's the theoretical max of what we might be able to attain through a policy such as this one. So with that brief overview, I'll turn it over to Mathieu, who's been leading our work to talk about the data and the research that he's been doing.
So thank you, Ben. So I will start by describing the model and then just show how we used it to answer that question. So the Wristband model is a state transition model, and it describes OUD as a series of transitions between 4 main states that you can actually see on this slide, which are active non-injection drug use, non-active non-injection use, active injection use, and non-active injection use. And the movements between these states simulate OUD as relapsing and remitting condition through active and non-active use, and also allow for escalation from non-injection to injection use over time. And obviously, these states have different overdose risks. Then, of course, while being in these states, the population is also distributed according to its treatment use regarding OUD. So, for example, here, what you see on this slide is the so-called no treatment state, where the population in this state, within this state, do not benefit from any treatment. So then if we zoom out, at every time step in the simulation, a portion of the population can move into residential treatments with either initiating MOUD or not. And what you can also observe from this slide is that in the residential state, it only includes non-active drug use, because we made the assumption that it was a full abstinence-based residential stay with no overdose risk. Then, if we specifically focus on the population in residential treatment without MOUD, so in that case, the people living residential move through a 1-month post-treatment phase, which simulates an elevated risk of active drug use, and during which period of time they experience a very high overdose rate. Then, if we focus on the population in residential with MOUD, some of them remain engaged in their treatment, and in that case, they directly linked to outpatient MOUD. So in that case, they do not go to this post-treatment block, and they're going directly here. So it prevents them from going to post-treatment. However, in the same fashion as for the residential, those living outpatient MOUD also must go through this post-treatment phase. So actually it means that initiating MOUD in residential treatment does not convey a lifelong benefit, but rather it gives temporary benefits as long as the patients are not lost to follow-up. And this detail is actually important because it means that we realistically simulate retention and loss to follow-up from OUD treatment in the model. And lastly, of course, those in the no treatment state can spontaneously also seek MOUD treatment in the community. And again, this is very important because It means like, for example, in the hypothetical scenario where all residential facilities do offer MOUD. So in that case, that would not be the exclusive opportunity for the population to initiate MOUD, because they can either initiate MOUD within residential or directly in the community. So we used the Wristband model to simulate two different scenarios. The first one is the standard of care, or status quo, where we assume a 24% MOUD initiation in residential treatment facilities, and that among those initiating MOUD in residential, 60% are directly linked to MOUD care in the community. And the second scenario is the intervention, where, so we started to assume in this scenario that that actually all residential facilities do offer MOUD to their patients, and that among these patients, these new patients entering residential treatment programs, 60% of them do accept the initiation of MOUD. And the second assumption that we made in the intervention scenario is that all of these people initiating MOUD in residential were linked to MOUD care in the community. So we also performed this analysis according to two different perspectives. The first one is a closed cohort of patients in residential treatment. So in that case, we ran the simulation for 52 weeks, so 1 year, to project the outcomes. And what is important here is that there is no people coming into the model. We're just following a closed cohort of people starting in residential treatments. In a way, it is similar to a prospective longitudinal cohort analysis. And secondly, we run an analysis of an open cohort. So in that case, we populated the model of the entire population of people with OUD living in Massachusetts. So here, in every time step of the simulation, some new people entered the model, which actually described the incidence of new OUD. And again, also, in every time step of the simulation, those having no treatment could seek treatment either in residential or in the community. And so this simulation approach, I mean, the open cohorts, is actually the impact that we would expect at the population level if the state do implements licensure requirements so that the residential treatment facilities do offer MOUD to all of their patients. And finally, our main outcome was the number of fatal overdoses. So this graph shows the primary results for the closed cohort analysis. So remember, the closed cohort is when we're just following closed cohort of people all starting in residential treatment. So what you can see is, so the vertical axis is the accumulated number of fatal overdoses per 10,000 people, and the horizontal axis is the number of weeks. Then we have this solid black line, which depicts the outcomes for the status quo simulation, and the dotted red line, which depicts the outcomes for the intervention simulation. And what you can see here in terms of results is a clear and immediate impact of the policy. And ultimately, over the course of 1 year, the policy results in a 34% decrease in the total number of fatal overdoses in the year following the residential stay. So again, just want to make sure that this result is among a population in residential treatment facilities. So then this table presents the results for the open cohorts. So now if we look at the first row, for example, we see that for the status quo, the model projects 157,787 overdoses over the course of 10 years. And that the intervention, the policy would prevent actually 808 overdoses, which would ultimately give 0.51% reduction in the number of overdoses. And this is similar for reduction in terms of fatal overdose. So this might look very small, but this is actually due to the fact that compared to the closed cohort in this perspective, so we simulate the entire OUD population in Massachusetts. And among this population, just a small portion is seeking residential treatment, which explains why we do have this small impact of the intervention in the open cohort simulation. So then we ran some sensitivity analysis, specifically on the linkage rate. So these are the results for the closed cohorts, and it represents the percent reduction on fatal overdoses of the policy, of the intervention, compared to status quo. So if you look, for example, at the first bar at the left, it actually represents what I previously showed, which is the base case with a 100% linkage, so which comes to a 34% reduction in the number of fatal overdoses. And then by declining the linkage rate, so if it's 80% linkage, then we have a 27% reduction in fatal overdoses. And if it's 60%, 20% reduction in fatal overdoses. So I just want to make clear about some limitations of the model. The first one is that we used data from Massachusetts, and although we can likely say that that these results, the impact, are kind of generalizable to other states, we have to keep in mind that the MOUD use in residential treatment programs in Massachusetts is relatively high, and probably that in some other states with relatively lower use of MOUD in residential facilities, the impact would be bigger in that case. Also wanted to mention that the model parameters that we developed actually reflect historical trends in overdose data. So actually, there might be some unexpected changes in drug use or policy that could affect future outcomes. So to conclude, we used that model simulation to project the impact of using state licensure standards that the residential facilities do offer MOUD to patients. So first, we showed a substantial decrease in the number of fatal overdoses thanks to that policy among patients of residential treatment of 32%. Sorry, it's actually 34% reduction in the number of fatal overdoses. However, as you saw, we have a smaller impact at the population levels. So that's something very interesting. And this actually means that that kind of policy solely cannot really tackle in a substantial way the overall opioid overdose crisis. So it means that we should focus on multiple venues to tackle that issue. But nonetheless, this is still a very important and a key element, a key piece in the overall struggle against the overdose crisis. And finally, what we highlight here, and we think that this has some potential for discussion, and that's very interesting, is that actually improving MOUD initiation among residential clients is just, I would say, half of the world, because actually linkage to outpatient MOUD, as we showed, is also very, very critical. And so, yeah, that would be my last message from this presentation, say that this is also something that we would have to work on. So thank you for patience. And I just wanted to acknowledge some collaborators and, of course, the Arnold Foundation projects who's at the initiative of that. Thank you.
Great. Thank you both for that really interesting presentation in terms of being able to kind of model what we might expect here. I'd like to ask you both, have you presented this to policymakers? Who have you presented it to? But if not, what do you hope to do with it? Because I think, obviously this is really critical in terms of being able to kind of understand and how we move systems here. So what do you think, what would be your ideal state in terms of how you'd like to see this used?
I think Mattia's looking at me as the mentor. So no, we haven't. This is the first time that we've presented these data. In
Okay.
fact, we sort of, we fired up this project and got going and meeting with Janet and Zach to think about this because of this conference. It's something we certainly had sort of in the back of our minds as a plan to do. So it's a nice synergy there. It's right, it's a symposium that's actually generating new analyses and new research. And I'd be interested to hear from policymakers at this session, like, is this an effective way to present these data? And what are other outcomes that we could include? I'll put one on the list that we just haven't had time to do yet, which is costs and cost effectiveness. Clearly, that's what we do. But I'm interested to hear because I think this is important to show. And I think, again, I put it in chat and Mattia hit it, but I do really think that the linkage piece is one message that I would really like to have come out of these data because sometimes I feel like a broken record. We've spoken about the importance of linkage before in our writings and in other presentations and other settings. It feels like an intuitive concept that obviously, you have to link people to care. And yet, it's not in almost every conversation I have around MOUD, the conversation just goes directly to the offer and initiation, and people sort of overlook the linkage piece. And I think it's critically important, every bit as important as the initiation piece. So I think that's one message that we'd like to get out there.
Great. I think you're right, Ben. We certainly heard that with kind of broad-based efforts to scale up emergency department initiation, right, with buprenorphine. That where do I send people to? Often became a barrier. Sometimes it was a red herring for not really wanting to do it, but sometimes it was also a real-world barrier. Let me ask, since we're you guys are kind of at the end of the day here, and clearly a theme that kind of came up was in my kind of paraphrasing that, science and data are often insufficient to move public policy. And, clearly we saw with COVID that sometimes it doesn't make a bit of difference in terms of moving public policy. And Rebecca at the start of this talked about like sometimes winning hearts and minds is just as essential to, what we have to do. All of you have been doing this work for a long time. So how do we combine kind of the rich research and data that we have, just like we got presented, with other partners to be able to do it? How should we think about kind of the partnerships between the research community and other parts to really help kind of move this forward? Have you seen kind of, or been parts of experiences where we've been able to narrow that gap between research and policy by really effective collaboration? So I'll just kind of throw that open to you to kind of reflect on that and if you have examples of where you think that's been highly effective.
So I don't know if this was directly the angle you were thinking of going with this, Michael, but I have to say in the work that I've done over the years, partnering with a strong foundation that has the access to the policymakers, like an Arnold Foundation. In my experience, I've worked a lot historically with the Robert Wood Johnson Foundation, but having that sort of partner is really important because we as researchers have to maintain our objectivity. And the policy debate, sometimes the best way to sell something is not in its objective manner, but in a more compelling manner that changes the hearts and minds, as we were talking about before. If we do that, we become advocates instead of researchers. And so having agencies that we can partner with, sometimes it is a foundation, sometimes it's a research center that has strong dissemination methods like LDI. I think that there are these sort of intermediate vehicles that do the best job of bringing the best science to policymakers as well, because as we also know, not all science is good science. It's important to get the good science out there.
Great. Brendan, you want to weigh in here?
Yeah, I do. I appreciate the question. So I think that we all occupy a different place in sort of the research to policy advocacy ecosystem. I think I've gotten more comfortable being an advocate as time has gone on. But I also think it's very important to have a sense of humility as researchers about doing work on these topics. I think there's a sort of temptation to think that a lot of what we see in the world is a deficit, where if only these people knew what the evidence was, then lo and behold, they would be won over. And I think that's wrong for a couple of reasons. One of the reasons I think it's wrong is that there's incredible complexity around a lot of implementation of these issues. that we as researchers don't necessarily experience. I'm speaking for myself, I wasn't trained to read regulations and statutes and to understand sort of what happens in the implementation process. And so kind of even understanding kind of the status of policy as it's written and as it's implemented is very, very complicated. And I think the other bit of it is that sort of some of the assumptions and beliefs that we take to this field, I think, need to be confronted and questioned. So I'm a huge advocate for MOUD. I have no ambiguity in my mind about the value of it for patients, but I also think that we have a tendency to sort of look down on people who are unsure about how MOUD is going to actually work in their practice for their patients for different reasons, some of which may actually reflect real challenges that they have, getting a program started. So I think that kind of having that mindset that we're here to learn alongside the people that we're trying to influence, I think is really important.
Great. Ben, do you
Yeah,
have any reflections?
Well, I just want to maybe be a little bit provocative at the end of the day, and challenge, all of us and my research colleagues, really generally in public health, but certainly in substance use disorders, that I think we should, to some extent, lean into the fact that we are engaged in a political discussion, right? We are, like, we're doing this research, and we need to use best methods and scientific approaches, and not, and generate real data, which should go without saying, but also should never go without being said. But at the same time, public health is inherently political. Like, we're trying to change policy, and we're trying to change the way people interact with each other in political systems. And it's not political like Democrats and Republicans. It doesn't need to be partisan. In fact, when it's partisan, we've seen that it becomes destructive. But at the same time, we aren't agnostic to the results of these studies, and I think that's okay. And I think that that's important to bring that to when engaged with stakeholders. I agree with you entirely, Brendan, that we definitely are, myself included, sometimes guilty of looking down at people who disagree with us, or not understanding the perspective of folks or not understanding all the challenges that are out there in the real world. And I think that's really important. But I also think that, to some extent, right, change comes from some combination of political evolution and also pressure from outside. And to some extent, our public health research should be some of that pressure from outside, because this is a non-functioning system and our goal is to change it. And I think that's absolutely okay.
Yeah, yeah. Ben, if you don't mind, I'll give a real world example of that. In Massachusetts, obviously we had the compelling data around reducing overdose death and the standard of care. But it wasn't until parents started complaining to legislators that they couldn't get their kids into residential centers that we saw legislators actually supporting a regulatory change. So, I think it's really important to think about, whose other voices do we have to have at the table here to help move forward policies. And certainly having the research and the data are important, but also I think having the hearts and minds and the stories become kind of critical to the work that we're doing, and including those folks in kind of our research efforts from the very beginning, I think, are also kind of critical ingredients here. So we had a question from Josh Barocas, who said, a question to kind of policymakers, and I'm going to toss this to Brendan to see if your research uncovered any of this, was, would having payers, the state or federal government, cover the cost of licensure for residential centers be a carrot or an offset, if you will, to doing some of this work? Did cost come up in any of your conversations with providers or state folks as a barrier?
Yeah, so terminology gets a little tricky here. I think the thing might be accreditation from one of the major federal accreditation bodies, which does cost money. And Maryland, for example, has tried to roll a lot of the oversight into the accreditation process, so that some facilities might struggle a little bit to come up with the money for accreditation fees. I think there's like a separate conversation to be had about whether accreditation is really the right fix, because right now, for example, you can get accreditation from the Joint Commission without actually providing medication. So I think that there's a big role for the accrediting bodies to step up and really make this a requirement for getting their stamp of approval, which a lot of consumers try to look to when they're shopping for care, which is totally a nightmare. I mean, there's no well-functioning market for substance use treatment, which is a different topic. Cost, I think, is really hitting a lot of providers at the point where they need to figure out a lot of the logistics and sort of just practical structural accommodations to make this work. In a residential program, for example, you have to build some place for storage and meet the safe storage requirements for controlled medication. So if you don't have experience with that, or transporting patients to an OTP. So these are like all costs. I think that if you believe, as I do, the modeling that Ben and Mathieu provided, it's well worth the investment, but somebody has to come up with the money. So I think like there's some opportunity to infuse some funds through maybe the federal opioid settlements, or through time limited resources like through the American Rescue Plan, to go toward some of these infrastructure and logistics kind of changes. So there's a lot of issues in that.
Great. We're almost at the end of our time here, but I want to give our panelists an opportunity just to share any kind of final thoughts or reflections, either on this panel or on the day itself, before we turn it back to Zach to wrap it up.
I just feel very energized by the comments from our policymakers today, and I feel really excited about the possibility of expanding some of this, using leaning into the potential authority that SAMHSA has always had to try to be a little bit more hard-nosed about how they go about dispersing their funds. They've got a lot of strings that they could pull on. So I think we as a community can continue to push out evidence and lean on our policy friends to make some change. I think that we should feel energized.
I agree. It's such a breath of fresh air to see others thinking about the same issues with different approaches, but with the same framework. Or it's very exciting and encouraging, because I've just had a lot of personal interactions recently with folks who basically share my entire political perspective, and yet still, when this topic comes up, suddenly we find ourselves on very opposite sides of the table around harm reduction concepts and working with substance use disorders more generally. It's been striking to me how heavy the lift is. I've just had several. I'm like, gosh, if we can't get you on board easily, we have a heavy lift ahead. So it's great to find colleagues and like-minded, kindred spirits in this. So thank you, everyone. It's been terrific.
I would just also like to say, I think that I agree. The innovation that's happening on the ground is really exciting, and gives me a lot of optimism about what's likely to happen, to change going forward. I think mindfulness of the individual communities with those options is really important. There are certain communities you're not going to convince that opioid medication is an effective medicine. So we need to be mindful of that and continue to innovate and look for additional optimal therapies, and that's happening. So I think we're standing at a point with a lot of excitement going forward. I really hope, because we all recognize there's risks. All it takes is one person to overdose on buprenorphine in the right community for buprenorphine to all of a sudden be demonized in a way that could happen with Advil. And so just keeping that in mind as we go forward.
Great, good. Well, it's really been an honor to moderate this panel and to be a part of this webinar. To complete the football analogy, Zach, I'll punt it back to you.
Well, thank you all, and it really has been an honor to have you all participate in this, what I think agree is incredibly invigorating, optimistic. I promise everyone we didn't insist or send you guys a potion of Pollyanna, but I really feel like the optimism that I heard, the energy, the excitement about blending research and policy together to tackle this issue, particularly during these times when sort of public health I think has been beaten down in many ways. It's just really exciting. So stay tuned, everyone, for a variety of new opportunities to engage with CHERISH, with LDI and CHERISH in the future. We are committed to continuing to convene conferences like this every couple of years. We put out summaries, and if you haven't been to the cherishresearch.org website, you can find them there, as well as on the LDI website. There will be a deliverable product from this conference that it's a little bit TBD, but will summarize what some of our learnings, and we hope to get that in all of your inboxes soon. So with that, it's exactly 3 p.m. on Friday of long weekend, and we will close the conference. And once again, thank you so much to our panelists, and thank you to our participants for joining us, and everyone who helped make it happen. Thanks again.